Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections.
Glad to be here for this one.
Yeah, today we are tackling something incredibly sneaky. I want you to picture yourself on a quiet walk in the woods. It is a beautiful, crisp afternoon, right?
Oh, absolutely. Perfect hiking weather.
Exactly. You are hiking through a trail, leaves are crunching under your boots, and the brush is thick around your ankles. You brush your leg against a tall blade of grass.
And you probably don't even think twice about it.
Not at all. But on the very tip of that grass is an eight-legged assassin. It is no bigger than a single sesame seed, just waiting with outstretched legs.
Just waiting for a host to walk by.
Right. It latches onto your clothing completely unnoticed. It crawls to a warm, hidden spot on your skin, and it bites. But you don't feel a thing.
Which is the scariest part, really.
It is. And as it feeds, it unleashes a bacterium that doesn't just invade your body, it actively hunts down and hides inside your white blood cells.
It literally turns your own defenses against you.
Today, the mission of our deep dive is to track down this hidden microscopic hijacker. We are pulling our intel directly from the CDC's official guidelines and a really comprehensive clinical overview from Stat Pearls to understand exactly what we are up against.
It's a fascinating pathogen, truly.
It really is. Okay, let's unpack this. What exactly is entering the bloodstream during that silent bite?
So the villain in this scenario is a bacterium called Anaplasma phagocytophilum.
That is a mouthful.
It is, yeah. In the medical literature, they define it as an obligate, gram-negative, intracellular bacterium.
Okay, let's break that down because those terms actually tell us a lot about how this pathogen operates.
Exactly. So gram-negative means it has a very thin cell wall, but it's protected by this outer membrane. It acts almost like an invisibility cloak, making it incredibly hard for certain standard antibiotics to penetrate.
Oh, wow. So it's armored from the start.
Yeah, basically. But obligate intracellular is the real key here. It means this organism cannot survive on its own in the environment. It absolutely must live and propagate inside a host cell to survive.
You know, I was reading through the Stat Pearls overview, and I was just struck by the audacity of its survival strategy.
It's brilliant in a terrifying way.
Right. It's not just floating around in the bloodstream causing trouble. It's actively breaking and entering into our cells. If we think of it like a burglar who breaks into a building to hide, this bacteria is literally breaking into the police station.
That is a perfect way to visualize it. It specifically targets our primary immune defenders, the polymorphonuclear cells.
Which we commonly call neutrophils, right?
Right, the neutrophils. These are the frontline police officers of our immune system. Their entire job is to patrol the blood, track down invading bacteria, engulf them, and destroy them.
But Anaplasma doesn't get destroyed.
No, it's uniquely dangerous because it actively evades their antimicrobial weapons. When it gets engulfed by the neutrophil, instead of being digested, it hijacks the cell's internal machinery.
Just sets up shop right inside.
Literally. It creates a cozy little cytoplasmic vacuole, a microscopic safe room, if you will, and it actively survives and multiplies right inside the cell designed to kill it.
I mean, I need to make sure I understand the mechanics of that because it sounds impossible. How does it stop the neutrophil from just, destroying that safe room?
Well, it alters the cell's biological signaling. Normally, a neutrophil uses lysosomes, which are essentially cellular incinerators filled with enzymes, to digest whatever it swallows.
Okay, so it throws the bacteria in the incinerator.
Normally, yes. But Anaplasma produces proteins that actually block those lysosomes from fusing with its safe room. It also delays apoptosis, which is the cell's natural programmed death.
Wow, so it keeps the host cell alive just long enough to breed.
Exactly. But the real destruction comes from the collateral damage. The presence of Anaplasma deactivates the neutrophil's ability to fight off other things while simultaneously tricking your body into releasing a massive flood of cytokines.
Cytokines are basically the chemical alarm bells of the immune system, right?
That's right.
The Stat Pearls report mentioned a cascade of interleukin-10, IL-12, and IFN-gamma. For someone without a medical degree, what is that actually doing to the patient?
It is causing a massive, uncontrolled inflammatory response. Those specific cytokines, particularly IFN-gamma, activate other immune cells called macrophages.
Which are like the heavy artillery?
Exactly.
Yeah.
But because the bacteria is safely hiding inside the neutrophils, the macrophages can't get to it. So your immune system is essentially throwing everything it has at the infection launching chemical grenades in every direction.
And the resulting inflammation just ends up destroying your own healthy tissue.
Right.
So the body is burning down the house to kill the spider, but the spider is safely sitting inside a fireproof safe.
That is the tragic irony of the disease. The bacteria itself doesn't cause the tissue damage. Your own immune system does.
This sounds like a plot from a science fiction thriller, but, I was surprised to see in the CDC data that this isn't some ancient plague we've been battling since the Middle Ages.
No, not at all.
The history of this disease is remarkably recent, isn't it?
Very recent. Human infection with this specific pathogen was first reported in 1994.
Wait, 1994? That is practically yesterday in medical terms.
It really is. It was discovered by a researcher named Chen and his colleagues. Before that, we had absolutely no documented awareness that this specific pathogen was infecting humans.
And reading through the history, it went through a bit of an identity crisis in the medical community. The literature from the 90s refers to it by a completely different name.
It did, yeah. When it was first discovered, scientists noticed it was similar to another tick-borne bacteria. So they named the disease human granulocytic ehrlichiosis, or HGE.
Right, HGE. I saw that in some of the older case studies.
But as DNA sequencing technology advanced rapidly in the late 90s and early 2000s, we were able to look at its specific genetic code. And in 2001, the organism was officially reassigned to the genus Anaplasma.
So today, we call the disease human granulocytic anaplasmosis, or just anaplasmosis. I'm stuck on something here, though. If this bacteria is an obligate intracellular organism, meaning it absolutely needs a living host cell to survive.
Right.
It can't just be sitting in the dirt waiting for a tick, right? Where is it living before it gets to us?
What's fascinating here is the silent ecosystem it relies on. It circulates quietly in wild mammals.
Like mice and stuff.
Mostly, yes. In North America, the primary host is the white-footed mouse, known scientifically as Paramescus leucopus, alongside the white-tailed deer. The cycle is just continuous in the wild.
So how does the tick factor in?
Well, larval ticks, which are, barely visible to the naked eye, feed on an infected mouse in the spring or summer. The tick ingests the blood, acquiring the bacteria.
Okay, so the baby tick is now infected.
Right. As the tick molts and grows into a nymph and eventually an adult, it requires larger blood meals. That is when humans accidentally step into the food chain.
And the mice themselves are just fine, right? They aren't dying off from this immune system hijacking.
Correct. Over countless generations, the white-footed mouse has developed a natural immunity to the organism. Their immune systems manage the infection, which actually decreases the transmission rate over time in wild populations.
The luxury we do not have.
No, humans do not have that evolutionary luxury at all.
Which means we are highly vulnerable when that tick decides to bite us. Now, the CDC guidelines highlight that this is a vector-borne disease, relying entirely on the tick as a vehicle.
The tick is the only natural way to get it, yes.
But depending on where you live, the culprit changes. It's not just one species of tick globally, is it?
No, it is highly regional. In the eastern and midwestern United States, the vector is the black-legged tick, which people often call the deer tick.
Right, the classic deer tick.
On the west coast of the U.S., you're dealing with a cousin species, the western black-legged tick. If you are listening in Europe, the primary vector is a tick called Ixodes ricinus.
And what about Asia?
In Asia, it's Ixodes persiccatus. So the geography dictates the specific vector, but the mechanism of transmission is identical across the board.
Reading about that mechanism was a huge relief, actually. The tick bite itself isn't an instant injection. If the tick's mouth parts break your skin, you aren't immediately infected with anaplasma.
No, you aren't. And this is perhaps the most crucial, actionable detail for public health prevention.
Okay, lay it on us.
The tick must be attached for 4 to 24 hours to successfully transmit the infection.
Wait, 4 to 24 hours? Why does it take so long? What is happening during those hours?
Well, the bacteria is largely dormant in the tick's midgut. When the tick begins to feed on warm human blood, the temperature change and the influx of nutrients wake the bacteria up.
So it's essentially hibernating until mealtime.
Exactly. It then has to multiply, detach from the gut wall, and migrate all the way up into the tick's salivary glands before it can be injected into your bloodstream along with the tick's saliva.
That journey takes time.
It does. If you find a tick and remove it immediately after a hike, your chances of avoiding the infection are significantly higher.
That window of time is a literal lifesaver. But the StatPearl's overview mentioned a secondary route of transmission that doesn't involve a tick at all, and it's pretty terrifying.
You were referring to transmission via blood transfusion.
Yes. How does that happen?
Because anaplasma lives inside white blood cells, a blood donor who is infected and who might feel completely fine, by the way, can unknowingly pass the bacteria into the blood supply.
And then it just gets bagged up and sent to a hospital.
Right. When that blood is transfused into a recipient, the bacteria has a direct route into a new host. It is rare, but medical professionals have to maintain high vigilance for patients who mysteriously develop severe fevers and immune crashes after receiving a transfusion.
Man, that is wild. Once the bacteria is in, whether by a tick crawling up your leg or through an IV bag, the clock starts ticking. The incubation period, the time before you actually feel sick, is about 1 to 2 weeks.
That's the standard window, yes.
And looking at the demographics of who actually gets sick, the numbers tell a very specific story, don't they?
They do. Geographically, in the United States, cases are heavily concentrated in the Northeast and the upper Midwest.
Which tracks with the deer tick populations.
Exactly. Demographically, anaplasmosis can strike anyone, but it is overwhelmingly more frequent in men over the age of 40. Statistically, men have a 1.4 times higher likelihood of contracting the infection compared to women.
Is there a biological reason for that, or is it just lifestyle exposure?
It's widely considered to be a mix of occupational exposure like forestry or landscaping and outdoor recreation habits like hunting and hiking, which skew heavily toward older males in these endemic areas.
Makes sense.
But while middle-aged men catch it most often, they aren't necessarily the ones in the most critical danger. The overall case fatality rate is thankfully less than 1%.
That is good news. But there are high-risk groups, right?
Yes. If you are over 65 years old or if you have a weakened immune system, the risk of a fatal outcome skyrockets.
We're talking about cancer patients undergoing chemotherapy, individuals with advanced HIV, or people who have had organ transplants and are taking immunosuppressive drugs.
Precisely. Their immune systems are already compromised, so they can't fight off the initial bacterial invasion, and the resulting inflammation just overwhelms their organs.
But on the complete opposite end of the spectrum from those severe cases, there is a phenomenon occurring in the general population that completely changes how we view this disease.
The asymptomatic cases.
Yes. Here's where it gets really interesting. Reading the StatPearls data, my jaw dropped at the cross-sectional seroprevalence studies.
The numbers are pretty shocking.
Researchers took blood samples from a wide swath of healthy people in heavy tick areas. They found that up to 15% of the population in northwest Wisconsin has antibodies for Anaplasma.
And 12% of the population on Sweden's coastal islands have those exact same antibodies.
What that implies is staggering. Having those specific antibodies means those individuals were bitten by an infected tick, the bacteria entered their bloodstream, and their immune system fought a microscopic war and won.
They retain the molecular memory of the invader.
But these people never reported a history of clinical illness. They never got sick enough to go to a doctor. So 15% of people in northwest Wisconsin survived an encounter with an immune-hijacking cellular assassin, and they probably just thought they were a little tired one afternoon.
It proves that a vast number of infections are entirely subclinical. The human immune system, when healthy, is remarkably adept at clearing this pathogen before it can trigger that massive, destructive cytokine storm.
But for the unlucky ones who do get sick, what is actually happening in the body during that first week? If that 1 to 2 week incubation period ends and the bacteria takes hold, what are the early warning signs?
Early illness, typically days 1 through 5, has a very sudden and aggressive onset, but the symptoms are frustratingly nonspecific.
Nonspecific meaning it just feels like everything else.
Exactly. You are going to experience a sudden high fever, severe chills, a splitting headache, nausea, vomiting, and diffuse muscle tenderness.
Diffuse muscle tenderness, meaning your muscles ache deeply all over your body. That sounds exactly like a terrible case of the summer flu.
It really does.
How would you or your doctor know it's a tick-borne disease? Especially since, unlike Lyme disease, you aren't getting a giant red bullseye rash on your skin.
That lack of a rash is a critical diagnostic hurdle. A rash only appears in about 10% of anaplasmosis cases.
Only 10%.
Yeah, and usually that only happens if the patient is simultaneously co-infected with Lyme disease from the exact same tick bite. If you just have anaplasmosis, your skin will look completely normal.
Reading the clinical overview, I saw that diagnosing this without a rash forces doctors to play detective with blood tests. They are looking for specific markers of organ stress, right?
Yes. The routine blood work will often show leukopenia and thrombocytopenia, which translates to abnormally low white blood cell counts and low blood platelets.
What about the liver?
They will also see elevated liver transaminases. Transaminases are enzymes inside your liver cells. When the liver is inflamed or damaged by the body's immune response, those enzymes leak into the bloodstream.
So if a doctor sees a patient in July with a high fever, no rash, low platelets, and a stressed liver, anaplasmosis should be at the top of their list.
Absolutely. But to get a definitive 100% confirmation, the pathology lab actually has to look at a peripheral blood smear under a microscope.
And what they are looking for is visually striking. They are hunting for something called morulae. Can you explain what a morulae actually looks like?
Morulae is Latin for mulberry. When the pathologist looks at the patient's neutrophils under a high-powered microscope, they're looking for dark, clustered masses inside the cell.
And they literally look like tiny mulberries or blackberries.
Exactly. Those are intracytoplasmic aggregates, actual visible colonies of the Anaplasma bacteria huddled together inside the safe room they build. Spotting those morulae can diagnose up to 80% of symptomatic patients before therapy even starts.
That is incredible, visually catching the burglar hiding inside the police station. But if a patient ignores the fever or the doctor misses the signs and the infection is left untreated, how bad does the downward spiral get?
It gets severe very quickly.
Yeah.
If treatment is delayed, up to half of all symptomatic cases require hospitalization.
Half. That is a massive escalation from a disease where 15% of people don't even know they have it.
It highlights how volatile the immune response is. Once it progresses to late-stage illness, patients face respiratory failure, severe bleeding disorders because their platelets are depleted, septic shock, and multi-organ failure.
I read it can also attack the nervous system.
It can. The central nervous system is rarely involved, but the peripheral nervous system, the wires connecting your brain to your body, can be severely damaged. The immune response can literally strip away the protective coating of those nerves.
A condition called demyelinating polyneuropathy. That explains why the Stat Pearls report mentioned bilateral facial nerve palsy. The inflammation is literally paralyzing both sides of a patient's face because the cranial nerves are short-circuiting.
Exactly. And recovery from that kind of profound neurological damage can take months of intensive rehabilitation.
Okay, let's unpack the treatment because the CDC guidelines are very clear that if you catch it early, modern medicine has an incredibly effective weapon.
We do, thankfully.
The standard of care is an antibiotic called doxycycline.
Doxycycline is the absolute first-line treatment. The standard protocol is 100 milligrams taken orally twice daily for 14 to 21 days.
And they start that right away.
Immediately. Doctors are instructed to initiate this therapy based on clinical suspicion alone. You do not wait for the lab to confirm the morulae under the microscope, because every day of delay heavily increases the risk of those severe neurological and organ complications.
I want to dig into why doxycycline is the chosen weapon here. It's not just blowing up the bacteria's cell wall like penicillin would, is it?
No, it's not. Remember, Anaplasma is gram-negative. It has that protective outer membrane that makes cell wall-destroying antibiotics ineffective.
Right.
Doxycycline belongs to a class of drugs called tetracyclines. It is lipophilic, meaning it can easily pass through fats and membranes.
So it passes right through the neutrophil's wall.
Yes, right through the neutrophil, right through the vacuole safe room, and enters the bacteria. Once inside, it binds to the bacteria's ribosomes, literally jamming the gears of its cellular machinery so it cannot synthesize the proteins it needs to multiply. It freezes the infection in its tracks.
But wait, I have to challenge this based on standard pediatric guidelines. Doxycycline is a tetracycline, and those are famous for permanently staining young children's developing teeth.
That is a very common and historically valid concern.
I thought pediatricians were strictly warned against giving that class of antibiotics to kids under 8.
Tetracyclines do bind to calcium, which is why they can discolor developing enamel. However, the American Academy of Pediatrics and the CDC explicitly override that rule for anaplasmosis and similar rickettsial diseases.
So they recommend doxycycline for adults and children of all ages.
Yes, they do.
So it's a calculated risk. The threat of multi-organ failure outweighs the risk of cosmetic tooth staining.
Precisely. Saving a life takes precedence. Doxycycline is the most effective drug, and withholding it can result in death.
But do they do anything to minimize the dental risk?
Yes. To minimize that tooth discoloration risk in children younger than 8, pediatricians employ a specific strategy if the child is suspected of being co-infected with Lyme disease. They use doxycycline to knock out the immediate, life-threatening anaplasma infection.
Okay, so they start with the heavy hitter.
Right, but they only keep the child on it until they've been fever-free for 3 days. Then they switch the child to a different antibiotic, like amoxicillin, to finish the 14-day course required to cure the Lyme disease component.
You mentioned co-infection there, which brings a huge twist into the treatment protocol. What happens if a patient is put on doxycycline, but after 3 days, their fever hasn't broken and they aren't improving?
If there is no clinical improvement after 3 days of doxycycline, the doctor must immediately pivot and suspect a co-infection with Babesia.
Babesiosis is another tick-borne disease, right?
Yes, but it is caused by a microscopic parasite, not a bacterium. It infects red blood cells, akin to malaria.
Oh, wow.
And because it's a parasite, doxycycline is completely useless against it. The patient will need specialized antiparasitic medications to survive.
Man, the tick is just packing all kinds of weapons. So what does this all mean for our long-term defense? If doxycycline is our only real weapon after the fact, and the diagnosis is incredibly tricky, do we have a vaccine to prevent the infection from taking hold in the first place?
We do not. There's absolutely no human vaccine available for anaplasmosis.
Not at all.
None. Researchers have developed veterinary vaccines because this disease heavily impacts livestock, like sheep and horses, but translating that intracellular immunity to a safe human vaccine has proven incredibly difficult. We are entirely dependent on preventing the bite.
Which means individual action is our only shield. The CDC's infection control guidelines harp on that 4 to 24-hour transmission window. The best defense is physically checking your body and removing the tick before the bacteria can migrate to its salivary glands.
Exactly. Wearing light-colored clothing doesn't repel ticks, but it makes an incredibly tiny, dark brown tick much easier to spot before it reaches your skin.
And repellents.
Using EPA-registered insect repellents containing DTEAT is essential in endemic areas, and meticulous tick checks on your hair, behind your ears, and in skin folds after any outdoor activities are mandatory.
From a public health standpoint, trying to control this disease must be a nightmare because the vector itself is so chaotic.
Public health officials face a massive challenge because the Ixodes tick is essentially nature's dirty needle. It frequently transmits multiple pathogens simultaneously.
It's like a roulette wheel with every bite.
Very much so. A single bite can inject a human with Lyme disease, Babesia, Ehrlichia, Rickettsia, and the Powassan virus all at once. The overlapping symptoms of those diseases make clinical diagnosis and epidemiological surveillance incredibly complex.
And looking at the surveillance data, we are clearly losing ground. Between the year 2000 and 2010, reported cases in the U.S. spiked from just 346 to over 1,700.
And it kept climbing.
Yeah, by 2016, that number jumped to over 4,100 reported cases. Anaplasmosis is endemic, and the incidence curve is pointing sharply upward.
If we connect this to the bigger picture, those surveillance numbers are just the tip of the iceberg.
Because of the asymptomatic cases?
Exactly. Because of the high rate of subclinical, unreported cases like those 15% of people in Wisconsin, the true number of humans interacting with this pathogen every year is likely exponentially higher than what public health dashboards show.
As those numbers rise, researchers are looking toward the future, and the genetic tree of this pathogen is branching. The Stat Pearls report highlighted emerging variants, specifically one detected in northern China called Anaplasma capra.
Yes, Anaplasma capra primarily infects goats, but recent studies show that approximately 6% of tick-bitten humans in that specific region tested positive for it via PCR.
Wow, 6%. Did they get sick?
They did. They presented with febrile illness and sometimes an eschar, a dark necrotic scab at the bite site. It proves the pathogen is finding new pathways into the human population.
And as it finds new pathways, the medical community is bracing for a rise in its most severe complications. There is one condition in the clinical overview that reads like the ultimate horror movie ending for the immune system, HLH. Can you translate what that actually is?
HLH stands for hemophagocytic lymphohistiocytosis.
Okay, definitely just sticking with HLH.
Yeah, it's easier to say.
Mm-hmm.
But it is a terrifying runaway immune reaction. What happens is the macrophages and lymphocytes, the heavy artillery of your immune system, completely lose their normal downregulation.
They essentially forget how to turn off.
Exactly. The cytokine storm reaches a critical mass, and your immune system stops targeting the bacteria and starts actively consuming your own red blood cells, white blood cells, and organ tissues.
That is the ultimate betrayal. The cells designed to protect you, hijacked by a bacteria you never saw, triggering a storm that destroys your body from the inside out.
It's devastating. And this raises an important question about our future preparedness. As climate change alters ecosystems, tick habitats are expanding rapidly into new geographic regions, bringing this hidden hijacker to populations whose immune systems have never encountered it.
It is a profoundly sobering thought. Given everything we've covered today, that up to 15% of people in endemic areas are walking around with antibodies, having survived a cellular war they didn't even know they were fighting, and that the tick's territory is expanding globally, you have to wonder.
Wonder what?
How many of us are serving as silent battlegrounds for a microscopic assassin right now? Next time you brush past a blade of grass, remember the complex, invisible world waiting on the other side. Stay informed. Stay prepared. This has been Outbreak Brief.